Avoiding needling, cupping on Moxa accidents, something that sits in the back of everybody's mind. Today, we're going to abolish this problem for good. Coming up. So can you tell us some maybe real life scenarios of injuries that possibly happened during an acupuncture session?
Areas of the body like wrists and knees and ankles, they had been very aggressive around the elbow points and they had damaged.
Let's assume the blisters happen.
Mm-hmm.
What kind of action should I take?
I've really appreciated being on that board because I get to see that the medical community wants to keep the public safe. But
Hi guys, Hisham Amr here from AcuAdvisor, and today we have an exciting episode about how to avoid needling injuries at all costs. And today we have the needling anatomy guru, Dr. Pat Cassello from Northwestern Health Sciences, that taught us how to avoid these mistakes at all costs. He actually took us inside the cadaver lab where we put the needle inside the cadavers and see the different layers of which that needle is going through. Go ahead, Dr. Pat.
hello, Hisham. Thank you for having me on here. It's so good to see you again.
Absolutely. Thank you.
Well, I am by license, a licensed acupuncturist, also a chiropractor. I work at Northwestern Health Sciences University. I was faculty there for many years. And one of the things, yes, that I worked in was working on anatomy and physiology and taking our students into the cadaver lab so that we could look at abnormal structures, for example, as well as depth of needle and the positioning of needles so that we could avoid structures like organs, major vessels, and nerves in the body. So thank you for that walk down memory lane. My work recently has been involved in doing more administration for the university, where I oversee the development of some of our new programs and continuing education, all related to our health sciences and clinical work that we do in there. And I have been a clinician for many years as well. I was up in our clinic, in the Bloomington Clinic on the campus, until about a year and a half ago when my administrative duties and travel for work just became enlarged and I needed to kind of balance everything out like we all do in there. But I love always looking at safety for patients and how we can give them the best care. And when I was working clinically there at the university, I had the opportunity to work in many different environments. I saw lots of different patients that might have various conditions and frailties. So hospital systems, transitional care units, and community outreach clinics as well. So I'd see everything from kind of community style acupuncture to inpatient and outpatient care in organizations as well as private practice, which really gave me a good look at how do we keep people safe.
In the back, at which vertebrae level can we actually go deeper?
Yeah, with spinal care, now the spine has four basic, curves to it, portions to it. And some of them are curved closer to the surface of the body, and some of them are deeper into the body. So if we go from the top down, the cervical spine, although there's lots of structures in the neck, certainly both in the front and the back part of the neck, the cervical spine actually gives us a little more tissue to play with. Muscles of the back that parallel the spine are usually a little bit thicker in there. And so you can tend to insert a little more. When you get to the transitional pieces, so like when the neck meets the upper back, that's a transitional place where the vertebrae are coming closer to the surface. So there it's a little more dangerous to go deep. As you work your way down the back of the spine, as you're going down the thoracic spine where all of the ribs are coming off of it, there we've got a couple of problems. One, the curvature of those vertebrae are very close to the surface of the body, which means you don't have to go very far before you start to get the interior. And underneath there, you've got the lungs. Now, as you're closer to the vertebrae, you do have some things like vessels and nerves running close to it. But you also have the muscle there. And the lungs actually have a little bit of distance between the spinal cord itself and the vertebrae and moving away from that area. So the farther you go away from the spine, like if you're going to do the outer bladder lines, for example, or you're going to go further than that out there, now you're in much greater danger of hitting the lungs than if you're really close, right? If you get down then to where the thoracic spine, the end of the rib cage, and where the low back is, now we have those nice thick lower back muscles, and the curvature of the vertebrae has gone internal again. It's gone deeper into the body. So there you have a lot more flexibility on going deeper, being more aggressive, like with your stimulation in there. And then we get back to the sacrum, which once again has a fairly superficial positioning to it. And at that case, you're often working maybe with the foramina, the holes where the nerves come through out of the sacrum itself, the bony prominence at the over the butt area, and you do have vessels there as well. But the bone is going to protect, portions down there as well. So if you're getting into the foramina, like they do a lot of that with low back pain, they do it with a lot of menstrual irregularities and issues with gynecology, and you get down into that, it's kind of like that's a little bit, it's like a squishy material because you've got a lot more connective tissue that's allowing those nerves and those vessels to come through, and it gives you room to play, but it's also a little bit more of a resistance to it. So you have to be really paying attention to how your patient's responding to that, if that's very painful to them, if you're hitting those structures. And over time, people that do a lot of that work tend to feel it in their fingers when it's a nice clean insertion or when they're needing to back off of a structure. So the spine, and a lot of times people sometimes are more afraid of it than they need to be. It's certainly important to be mindful, but there's some areas like low back and even in parts of the neck that you can actually do a fairly decent insertion. Once again, listen to your patient, listen to your feeling in your fingers.
So can you tell us some maybe real life scenarios of injuries that possibly happened during an acupuncture session?
Sure. I've worked in a variety of environments. So I've been in the hospital systems. I've been did quite about a year and a half of time at Courage Center, which is a transitional care unit where we had a lot of both spinal cord injuries and stroke patients. And that situation in particular gave me lots of opportunity to really see what happens when we're working with patients who are really in a much more frail state than, say, maybe our common person that might be coming into our clinics. But I think gives us some good examples because things like strokes are very common out there as well, especially if you're treating like the elderly. And so, excuse me, when I was at Courage Center, some of the things that we would see would be, we would use electroacupuncture on the scalp a lot and on the spine, especially for like stroke patients. Well, with elderly patients, a lot of times the scalp is fairly fragile and you do have blood vessels, kind of on the surface areas there in the skin. And what we would find sometimes is we could get hematomas. You could actually get a little bit of rupture of the vessel and you get bleed out with that. So there would be bruising and could be pain, and we had to be really mindful of that a lot and how much we were going to actually be aggressive with the needling that we did.
Right.
So one of the ways to work around that would be that you could use, especially like let's say you're down back the back of the skull in there and you're closer to where the neck and the muscles and the connective tissue of the neck is. Well, then we could switch maybe to some of the attachments with the electrical devices, so we didn't necessarily needle them. We were actually using the wands to actually stimulate. And there you've got usually a cotton ball or something in the end you're going to wet, and that delivers electrical current through that device to them rather than do directly to the scalp. We also had a gentleman that we were just beginning to work with as a stroke patient, and we would put the needles in and try to give stimulation because you want to try to stimulate it most of the time for stroke patients. But in this case, we didn't know it, and neither did the facility, that he actually was prone to seizures. And we ended up having a seizure process happen, so we couldn't do that for him anymore. We had to choose some other methods to work with him, unfortunately, because scalp acupuncture is quite successful, generally speaking, with stroke patients. I've also seen where we've had problems, areas of the body like wrists and knees and ankles. Parts of those joints just don't have a lot of tissue, right? There's not thick muscle there. There's very thin skin there. And we've got a lot of transition areas for nerves and large vessels that are feeding those parts of the body. And so I've seen, especially with things like the heart channel and the lung channel, where you've got the radial and the ulnar arteries coming through there and nerves, that there's been problems. I've seen people be a little too aggressive, for example, in some of those points close to the wrist area.
I guess
And
there's not a lot of flesh in that spot, right?
There's just not. Yeah, there's not. I mean, you try to take, when you can, you try to grab that little bit of flesh and pull it up, give you a little bit of room, to move the needle into there. If you think of something like, like lung 7 area or in pericardium 6. And when if you aren't trying to do some of those things to miss some of those structures, you can have problems. And so one of the things that I've seen happen for people, especially, I would say, like trying to do heart 7 and trying to do like lung 8 and lung 7, they can catch either the nerve, which can end up in palsies, which means you kind of lose some of the ability to do the proper, in this case, flexion with the muscles in the wrist, or you can end up with hematomas because you've caught the relatively large arteries in the area. Veins will tend to give you more bruising. Arteries will tend to give you a lot greater distribution of blood in the local area.
I'm asking, like, is it dangerous to cause a hematoma? Will it go away on its own? Is there something that we could do to make it disappear quicker?
Yeah, so with hematomas, you've damaged the outer boundaries of the vessels. The vessels are basically leaking their fluids into the localized tissues. So one of the ways to work with those is quicker, like warm compressions. You want to get that to start closing up sooner with that, and depending on the amount of damage. And so if it's a relatively large, high pressured vessel, which some of those arteries are going into the extremities, you're going to get the blood escaping a lot faster and not as easy to close up. And then if you have somebody that's on blood thinners, for example, like warfarin, and like your heart patients, for example, may be on that type of medication, the blood does not clot as well at the same time. So you want to get compression, and warm compresses are better, and that will help usually the clotting process to be faster. Now, if you have somebody that's really the clotting just isn't taking place, it might be more serious in there. And it might not even have been necessarily a big injury, but for that person whose clotting ability has been compromised, then it's more serious, and you might have to actually have them transferred in some way into a facility that can work with that. But generally speaking, I found with hematomas, it's fairly contained for the average patient out there.
That's what
They may not be large, and as long as you have if you have some equipment there, if you have sterile gauze you can use, for example, if it's pierced out through the body, if it's starting to bleed through the skin itself, and tape, breathable kind of tape that you can help close some of that up. If you have those type of things, usually they will recede on their own. The body can reabsorb the blood. Just like if we get a bruise, like if I was playing a sport and I got a bruise, well, eventually the body will resorb that as well. For a person, it becomes more critical when you have frail patients, vulnerable patients. And so that could be people who are very old and of some of the clotting and the circulation, cardiovascular system is more compromised for them. If you have damaged tissues, like if somebody has a lot of spider veins or varicose veins, which is an already damaged vessel in the area, if they are hitting a major artery, like let's say they were needling maybe like in the neck, around the SCM, you get in that lateral neck and you have the carotid arteries, which are major feeds to the blood to the head in the neck area. If we were to damage that, which is tough to do in a healthy carotid artery, but if you had somebody, let's say, that's had surgeries and has a port in their neck and some of those vessels have been damaged because that was used to put medication in or to take blood tests periodically for them, like chemo patients might have that. Well, that vessel has been kind of weakened, and so then there's a greater damage to be in that area. Post-surgical area is also another area where the tissue's been damaged because of cutting, even with laser surgeries. So you have to just kind of weigh everything that's going on with that patient. But for the average person, bruising is something that happens. We can't possibly see all the small vessels in there. And so when it does happen, you'll usually get kind of that enlarged area. You'll certainly see the bruise. Patients are going to feel it. They're going to see it. And so we need to respond to it. We want to let them know that generally, this sometimes happens, and hopefully we've already told them that in informed consent, and then help them to reduce that as quickly as possible. And usually we can. I mean, it has to be a pretty serious vessel or a really compromised patient for it to be something that really becomes great concern that maybe we can't handle.
What are some of the, if it's a big problem, what are some of the symptoms that we could possibly see to kind of know that it's more of a bigger problem?
Yeah. Bigger problems would be the bruise is expanding quite quickly. I mean, it's really spreading under the surface of the skin a lot. It's coming out through the skin. It's actually flowing. And with arteries, you're going to get more of like the spurting, kind of a blood, because it's a high pressured vessel, right? Where veins are more passive vessels, and so it will kind of drip out, but it still could be damage to that vessel as well. So if the blood's not really staunching after, if it's not starting to clot within a minute or so, you've got to be concerned with that. And that doesn't mean that, like, if you put a compress on it and then you lift it off and lift the pressure off and it starts to bleed a little bit, still that's kind of normal. But if you've had some pretty good compression on it and then it's still bleeding, that's more of a problem. So
the main ones are a hematoma or a nerve problem, right?
Yeah, that's the major common ones that are going to get damaged during needling.
With nerve issues, do you know of any scenarios in the past, real life scenarios that has happened where someone had nerve damage?
Yes, I had one of the patients that I treated, she had come in and she had a lot of problems with asthma and respiratory, and her immunity was pretty impaired, so she gets sick a lot. And so I was trying and wanted to use points on her arms, especially by the elbows, was wanting to work with like lung 5. And also I was wanting to work with some of the lung points up in the chest. She had a couple of things happen in some prior treatments. They had been very aggressive around the elbow points, and they had damaged both the ulnar and the radial nerves in those areas. And so she was really highly sensitive, and the last time had been about 9 months earlier, and she still couldn't tolerate any needling into those areas in there. She also had experienced from that there was some ongoing pain and sensitivity, but also some muscular. There was some hypertonicity that happened. The
Wow.
muscles had kind of guarded, around that, and so part of that was also causing some of the pain that she was experiencing
Mm.
in her arm. So I had to choose some other things to work with. I couldn't work
Wow.
with those specific points. Up in the up in like in the lung 1 and 2 area, up in the upper chest, they also had damaged some of the nerves coming through on the brachial plexus, which is the nerve groupings that come down and feed into the shoulder and arm. So it was really kind of, the arm was compromised in a lot of ways, with great sensitivity and pain for her, and some muscle guarding, which I could work in some other ways. I could work with the muscles in some other ways, but I really couldn't use the points that I would have really have liked to have used close to the shoulder joint and close to the elbow joint for her comfort with
Mm.
that.
And how is she doing today? Do you have any idea?
I haven't seen her in a couple of years. We were able to work with the complaints that she came in with. I was able to work with her asthma and some of the other issues that she had. The sensitivity was getting less while she had treated with me, and she treated with me for about a year in there, but the sensitivity was still there. And nerves, unlike other cells and structures of our body, really take a long time to heal. And so that sensitivity can really remain a long time. I had one patient with 5 years after an incident with the needling incident on the nerve. We just couldn't work with that area at all. So it really takes a long time for them to heal. We want to be
Yeah.
especially careful with that.
Another question that it's in the back of my mind, and I try to not actually go inside joints myself,
Mm-hmm.
but what do you think of inserting a needle inside the joint?
Well, inserting inside a joint means you usually have to go through the capsule and the other
Right.
structures that normally are protecting the joint.
Yeah.
And the joints are closed for a reason. They're holding usually fluid in there, which also is providing nutrients to the surrounding structures, to the discs, for example, like the meniscus in the knees, or the articular cartilage that's protecting around structures, the tendons and other structures of the knee and other joints. So,
But maybe I'm wrong. Maybe it's safer than what I think. But I'm just curious what you think of maybe doing the knees or the elbows, things like that.
yet working around them, because those are all great points, right? To work around them. To go into the space of the joint means you have to go through other structures to get there, and it's a greater risk of infection, for one, for a lot of patients in there, because you're opening spaces that normally they're closed to be protective in their closed state. And there's reasons sometimes why people do have to go on joints. For example, if we had cartilage break off, or you had a damage like in the knee with the internal tendons or something, to repair them, they have to go in, they have to cut through the structures, right? But anytime you cut through the structures, infection's one risk, but also they're kind of dense, irregular types of connective tissue. And so when you cut them, when they heal like scar tissue.
Mm.
So although needles are much finer than that, than say that a scalpel would be for that, but those are some issues that can develop for them. And so I like to leave the structures intact as much as possible. And I know there's people that do go into the joints and
Right.
work fairly successfully with them, but you are taking greater risks,
Yeah.
when you do that. Infection's probably the biggest one. And with people that are going to have trouble with the joints, if you're going in the joints, let's say somebody has diabetes, where you've got compromised blood vessels and compromised nerves, and the structures of the joint start to change over time. They're at greater risk already. We're already just kind of exponentially expanding that risk for them. So I would not, me personally, I would not go into the joints.
What about press tacks in the ears?
Press tacks have a similar issue. Now, the ears aren't very well vascularized. Their blood vessel system, which is our protective, it's our part of our immune process, since they're not as heavily laden with blood vessels in there. They don't really have a strong immunity either. Press tacks go in through the surface. They enter into the body, so they are invasive. They, on the practical side, they're painful. They're hard to sleep on for a lot of patients if they're side sleepers or whatever. So that pushes the tack in even further and can be painful and irritating. With that, press tacks, there's also the risk for infection there. I'd also be careful about the quality of people's ear skin.
Right.
I used to treat a number of patients from East Africa. It just happened to be that they were locally lived around the area, and so they would come in. And some of the people that have had treatment in other countries, cauterization was often used, where they'd actually burn. They'd actually do kind of like a burning scar tissue type of process on specific points for specific ailments. And to their credit, the spots that they were actually treating, those were great spots for that, for like sciatica. We would see a lot of sciatic points that would have these little thin kind of scars because of the burning that had been done with them. But it makes it very difficult then now to needle them. And so you had something like a press tack on top of that, or something, even needles going into that spot. That tissue was not very receptive to that. So it's usually pretty uncomfortable for the patient and might not be really highly effective either. So, and also some people have different changes in the ear structure. For example, young children that may have cretinism or autism or different diseases. What happens is during the developmental stage of the brain, the ear is developing around the same time. And so if there's changes in their development, the ear also doesn't develop into its normal structure. And so your landmarks for needling are off as well with that. And so you might be needling areas trying to work around that where underlying structures like vessels are changed from the normal ear. And that's always a consideration. When we learn anatomy, we learn kind of the average of where things are, but everybody's individual, and so they can change. And so what's really a safe insertion for one person, say at a joint, you might, 99 out of 100 times do that same kind of insertion, and then you can get somebody where a nerve is much more close to the surface of the skin. For example, down like in gallbladder 34, the common peroneal nerve, when it wraps around that upper fibular head there, sometimes is a lot closer to the surface and to the head where we normally would needle than another person might have in there. So
Okay.
I'm a big advocate of being risk adverse as best as possible, and being mindful of what's comfortable for the patient. Because we want them to come in for care. If they're taking something home with them, like a press tack, we want it to be as successful as possible. And so I know some people use them, and that's great. I'm just kind of giving my personal professional experience with that.
Okay. Now for cupping on Moxa, let's take cupping first. What are the biggest risks out there from cupping?
The biggest risk for cupping, leaving the cups on too long, for one, is an issue. Blistering happens a lot more commonly than people think. And so in some practices, because you're treating, and I had the same thing, I would treat around 3 rooms at a time. I was rotating through patients, so I'd go in and I'd do my intake and talk with them and set them up in their treatment. And we had monitors, and so if they need anything, they just pressed the button. We'd get an automatic notification we need to go back to a room, and then I go to the next patient, and then I'd circle back when it was time to take people off. So many people do that. They're not maybe working on just one person at a time. They're working on several. Cups left on too long cause, and not just even like little blister bubbles, but sometimes really big blister bubbles.
Right.
People with diabetes, people who are more, I call them more of the kind of the earth and water types. They're very yin, right? leaving it on too long. It'll just kind of, with that suction, take any of that extra water, in the skin and in the tissues up. And then compounded with that, usually, like here in Minnesota, because it's cold, and we often do cupping in the winter because people have been out shoveling snow and, fell down or, whatever, we're going to put heat on it too. We're going to put cup on, we're going to cover them up, and we're going to put a hot heat lamp or something on it, right? And so that makes it worse, exactly. And so shorter time periods, staying closer to people, really somebody new coming in, see what their body kind of tolerates. And the other part of cupping for me with blisters is, if it should happen, do you have the sterile gauze and the other things to help, kind of reduce those blisters while they're still with you, and talk to them about care and what they're going to experience with that. And I always talk to people when I'm doing cupping with the informed consent that there's certain things that can happen. I'm going to do everything I can to reduce all of that. But once in a while you get somebody, it doesn't take them very long on the table, and that can happen. And so to be really mindful about that, I think, is important. And also the sterilization of the cups is important. I know when I was over in China, when we went over for the trip, I was watching the cupping that they would do there, and it's very aggressive compared to what many people might do in the United States, but very effective also. Like low back, that was great to do, like bleeding and cupping. Well, in the United States, it's very frowned upon, of course, and so we lose some of that. But when we're doing like sliding cupping and stuff, we can disrupt the skin almost like gua sha can, right? And some people still will put a needle in and put the cup over it, and then when they take it off, you can get more bleeding. So you have to be careful that you can contaminate the glass cups. And then there's the ones that you can do with the pressure only, where you put the cap on and then you pump up the pressure rather than let the suction, from the fire cups. And that it doesn't take a whole lot of suction to really, create a good hold in that, but you got to be careful. And then of course you've lost the ability to do the sliding with that. And I love to do sliding cupping because that was really helpful for people, especially along that whole spinal column and the low back and the glutes.
Yeah. So let's assume the blisters happen.
Mm-hmm.
What kind of action should I take?
Well, if the blisters have happened, you usually want to get sterile gauze, have that available in your clinic. Could put compression onto the blisters to open them, to let them kind of disperse, because it's going to be uncomfortable if the person's trying to put the coat on, and then to cover them, right, to have that covered and tell them when they go home they can shower and whatever. It's probably going to sting a little bit with that. Some people will have topical like burn creams or whatever. It's not necessarily always from burns, but it's similar to the body's opened up, right? It's opened up that blister in there to help with healing. I had a special cream, an ADAP cream that had vitamin E and K in it that I would use if we had any problems with any of that, which really recovered the skin nicely quickly.
What's the cream called?
It was called ADAP, ADAP. It's a small company that actually sells that. I believe they're in Wisconsin. I have to look back at I don't remember if that's where they're from. I used to get it through the bookstore at the university from them. And I've used it for other things too. It has a really nice restorative property for the skin specifically. And it's a good product made with good ingredients in it. All right. The other thing for cupping, it just flashed to my mind, fire cupping, which I love doing in there, but you have to be mindful about your equipment and your technique there. Yeah. And so one of the things that can happen, I actually saw this when I was working with an intern. We were doing the fire cupping, and we were using the cotton balls that you soaked into the alcohol and wrung them out so you didn't have extra alcohol, and then you light it, you put it in the cup, right? And so she was doing that, and the cotton balls, I think, might have gotten a little old, and a part of the cotton came away from the rest of it while flame and fell on the bed next to the patient. and we quickly removed it, but it did heat
Yeah.
up a small portion
I
of the
think
person's.
that happened one time in my class also.
Mm-hmm.
The same scenario.
Yep. And so that I'd never seen that happen before. I was like, oh my goodness. And so we just quickly, applied some stuff onto to her back. She wasn't, it
And
wasn't a bad burn. It was just enough. It was a superficial, almost like a sunburn kind of burn, but certainly she was a little shook up, and my intern was a little shook up. And so, but we just talked the patient through it, and the intern, and said, this is a rare occurrence, but from now on we'll check,
yeah.
that the cotton's much more intact.
Now, I've certainly seen a ton of acupuncturists out there posting pictures on Facebook or Instagram of blisters.
Mm-hmm.
We don't know what it is. But now you just actually informed us why the blisters come in the first place, right?
Mm-hmm.
It's just the cups are on too long, correct?
Yes. Yep. Too long, and the if you have a patient with a lot of water metabolism, inhibition, like there a lot of swelling in there, for example, water collecting down on the ankles or in the skin a lot, you want to be cautious with the cupping, because the tendency is going to be for the body to want to expel it, and it's not internally doing it well, so it's going to try it through the skin.
Right.
And so you just need to really be mindful about when
How
you're going
long will the blisters disappear? I mean, does it take a week, 2 weeks?
Blisters can take usually, the ones that I've seen with patients, might be a few days if it's just a couple, smaller ones. If they had larger ones, a week or more to do that. And
Any scars that could possibly be left?
I've never seen scars on anyone, but I could see with repeated, because some people get a lot of cupping regularly, or a lot of a volume of cupping, a lot of cups being used in an area, and the skin needs its ability to restore. And so if you're doing a lot of repeated treatments over that, it's possible you might change it. Scarring is usually going to happen if we get below the epidermis, though. So if it's the superficial skin, that's a different type of tissue than the denser connective tissue beneath it, right? And so if you're really getting into the deep skin, where you're really continually disturbing that lower part of the dermis, that's where you'll get the scarring. Usually with the cupping, it's the epidermis that's impacted to begin with.
What about Moxa? I know a lot of people are scared to use it in case it falls on the patient.
Yeah, that's always the trick, especially with the thin moxa, like the little, if you're doing the little threads, or if you have the little, I call them the little hats. They're small little round pieces, almost about the width of a pencil, and you attach it with a little adhesive and you burn it down, but it burns fast, right? Yeah. And so the danger there is burning. And one of the most common things that gets people get sued for is for burns out there. I work, part of what I've done in recent years is I applied to be part of the Minnesota Medical Board. There's an acupuncture council where a number of us acupuncturists and some other professionals, we, in this circumstance, we're working as counsel to the state in the event of grievances coming in the door. And grievances can be anything from like malpractice and negligence to improper boundaries with the patient. Miscommunications about things are really common, where the practitioner said one thing, the patient understood it to be something else, or something's happened. But the most common things that end up going to court are things like burns.
Burns. What about pneumothorax?
Pneumothorax, they happen. They're not as common from acupuncture unless you're really going to be aggressive over the lungs, but they do happen and can happen, especially when you've got, once again, compromised patients. If someone have emphysema and the expanded chest, and now the normal depth of insertion around the lungs and the ribs is reduced. You have to be really careful because the lung shape and the chest shape has changed, and you can no longer kind of get that nice little flat, like if you're doing transverse insertions, you really have to be careful with that. If somebody had, well, I'll give you an example of what we do when I'm on the medical board, when I'm on the council. They provide us with the information of the case if somebody has put in a complaint of some kind. They give us the specifics because they need to make the official ruling on things like, are you going to fine somebody? Are you going to pull their license? Is there a safety issue here? You know, and so we want to do the best for the public, and we want to do in fairness to whoever the complaint is against as well. And so we will look at, did they use good standardized processes in decision making? And so we'll read, usually we get the notes of the visits, we get the information that came in from the person making the complaint in there. And then we as a group have that discussion to say, do we think they used wise judgment and were they using standardized procedures? Mm-hmm. And if they were, sometimes, I mean, stuff happens. Pneumothorax can happen even with the best of intention and what really seems like good processes. Usually, in the case when something like that would happen, we just find out through our observation that they did safe practice, but it was just one of those things. Things can happen. It's a risk when you do anything invasive, right? Absolutely. Every once in a while, though, we find out that we really look at the evidence and go, wow, they were really being very aggressive here or doing things that normally we wouldn't be doing, you know, as acupuncturists, for example. And then we give our opinion, our recommendation to the board, and then what they do with that is they bring the person in and they do further investigative work then at that point. I'm in there. We seldom have to go to that. Usually we can review a case and say, you know, they seem to really have used pretty good procedures here and it was just an unfortunate, you know, adverse reaction. And they responded well on top of it. When it happened, they took the proper precautions afterwards and tried to reassure the patient, you know, and do all those things. And so that's what we're always looking for. And I've really appreciated being on that board because I get to see that the medical community wants to keep the public safe, but they're also very reasonable in their process of investigation, which has been nice to see.
Very nice.
Yeah.
So what are some symptoms of pneumothorax? And in case we know for sure someone has pneumothorax, how can we act to alleviate the problem?
Mm-hmm. Pneumothorax, usually it's going to result in shortness of breath. And if you've got somebody that doesn't already have respiratory problems, for example, like they don't have asthma or emphysema, and suddenly they're wheezing and shortness of breath, that's usually the first indication. And pneumothorax can happen kind of at a superficial level, I'll call it almost a minor level, where you don't get any symptoms. It may aggravate throughout the day. And so people may go home, they were fine in the office and go home and then call and say, man, I'm really struggling here after, you know, that treatment we had today, right? So if they're still in your office and it happens right away, and that's usually where we've hit a major part of the lung or it was deeper and it's just, you know, just released more air around the lung and is collapsing it, they're going to struggle to breathe. That's the most common thing. Or they might even get a little faint, you know, and they get up because they're not getting the oxygen that they need, or the lung is suddenly, you know, changed. Ones that have changed after they left the office and they call, you want to inform them to have somebody take them in right away into an emergency room and have it checked out. And it may not have anything to do with the acupuncture, but now we have to think in terms, what's the best thing? And the best thing is to get them in and get that diagnosed, because the emergency room that they go to, for example, at the hospital, can take care of it much faster than we could ever do anything in the office. If it's in the office, we try to keep them calm. We call the paramedics for them and start that process so that they can be taken for more diagnostics and better care on the back end. We can't really reverse what's happened at that point in the office, but we need to care for them to get them to where they need to go.
Well, I appreciate your time with us on AcuAdvisor, Dr. Pat.
So great work. I love that you're doing that.
Thank you for being on here.
Yeah.
I'm very honored to have you here.